Good afternoon, guys. We are making way to prepare to go ahead and get started on our final hours, which is our last module of this LNET session. Thank you guys for your flexibility on last week because I was actually double booked and would not have been able to basically give it justice that it needed. So thank you for again for your flexibility. I do want to say before I actually start the session that with today being the final session, of course, chat box, your name, but I really would like for everyone that's on today, I'm going to be sending out separate emails, but I want to make sure that I have the sessions that you attended correctly. Um, it may take some time for me to go back in the chats and take a look to see who all was actually present. But today, if you're on, if you would please send me an email after this session, just confirming with me the sessions that you attended so that I can make sure to have that amount of time, excuse me, correct on the certificate. Also, if you have missed a session and would like to make that up, please make me aware of that so that I can make sure to get the recording. But please just keep in mind that the very first session, if you've missed that, that's going to be have to be a live session. So please, if that's something that you need to have done, to make sure that you make me aware. Of course, this is going to save some time on waiting for your certificate if I could get those emails kind of early on. That being said, today's session is final hours, and we will go ahead and get started. There was a saying that says, life is unpleasant and death is peaceful. It's the transition that's troublesome. After today's session, the hope is to be able to assess an imminently dying patient and be able to talk about those 5 physical signs and symptoms that happen during the dying process. Also, to be able to assess the physical, psychological, the social, and spiritual care needs that the patient and their family may have. Also, to discuss the role of the palliative care nurse surrounding the death of that patient. When we talk about preparing for a good death generally doesn't occur without some planning and some anticipation of the nurse and the team members. Of course, those nurses are invited to spend final days and moments with that patient and the family during this sacred time. So there's a video here that I cannot bring up, but there's a link right there that kind of gives an idea of a testimonial documentary, so to speak, that talks about what a good death actually looks like. And in taking a look at that, things like hydration, resuscitation, whether or not there's some hastened death requests. We're going to chat about that a little bit later on, but these are some things that the video talks about. And, the video also gives some concepts as to what a good death actually looks like. And so, there'll be questions that you'll be able to ask yourself after this video as to whether or not you think it's a privilege to care for people in their last days of life, and then whether or not you believe these experiences that you have, whether or not they encourage growth for you as a professional. So it's a really good little video clip if you would just take a moment to take a look at it. Of course, we know that everyone dies. That's just a part of the life process is that there's going to be a death. But, a lot of times people that are dying today, some have been sick for a long time, have had a lot of comorbidities. Some have suffered, their families are tired, financially broke. So these are things to just consider when you start thinking about those individualized deaths. Of course, advanced care planning, y'all, that is as important as laying out a blueprint for the patient's preferences regarding what they want to see happen at their end of life. It can actually increase the likelihood that the patients get the care that they want. It can also take down those care costs. It can improve their actual quality of life. And of course, increase those bereavement outcomes. So here's another little click. I don't know if this video, it's very short, but it kind of gives an idea as to what that looks like. And it also helps the nurse to be able to take a look at the care as they transition from to actively dying. And then, of course, it talks about the care that should be provided during this time and even the post-care death, once the pronouncement, taking care of the body, the burial plans, and the bereavement care. course, we know that, the nurses probably have more real exposure to death than any of the other healthcare on the team. But just keep in mind that it is an interpersonal uh, competence, which includes, being able to have empathy, and that is putting yourself in the patient's or family member's place, non-judgmental acceptance, being able to be genuine and open and trustworthy, and also paying attention to that detail, that critical thinking. Of course, the nurse should also be comfortable with being able to be with and to bear witness with the dying patient and their family. Please keep in mind that care of the dying has to be orchestrated in an interpersonal, disciplinary way. Of course, the nurse is going to collaborate closely with the physicians and with the chaplains, social workers, and all members of the team in order to provide care during this time. Randy, you have a question?
Hey, yeah, you're sound like you can hear you for a whole sentence and then it cuts out for a whole sentence.
Oh
So
no.
hard time following.
Okay. I'm sorry. I'm going to try to adjust that on this end. Thank you for giving me a heads up on that.
Yes, ma'am.
Can you hear me right in this moment?
Yeah, I can hear you now, and it's not like it's staticky or anything.
Oh, wow. Okay. Okay. I am sorry. What can you say about this stuff? I don't know.
Yeah.
Technology. So I'll just ask very briefly, has anyone had a recent death that you'd like to talk about? If anything went well, what could have been improved? Because these are things that as we experience deaths, that's probably the last thing on your mind in that moment. But looking back, being able to say, what did we do different? What could we do different? Was this a good death? Anybody want to elaborate on that?
I think probably one of the biggest things is having what you need in the home. Um, as far as from a
Right.
but having what you need in the home because there's nothing worse than family that wasn't ready, I guess,
Right.
and they didn't let us get comfort meds, and then all of a sudden mom transitions and you have to work with the very
Yes. Not
you're
having
struck,
enough of what you
you know,
need.
yeah,
Exactly. I agree.
everybody's on board and in a perfect world that's the best case scenario. So
Right. Right. Thank you. Anybody else? No worries. We'll move right along. Um, thinking about open and honest communication, this fosters trust and informed decision making when they can, when we're open and honest and able to communicate. I think that when we speak, we have to convey that caring and sensitivity and also the compassion, because believe it or not, they can hear radio voice versus actual compassionate conversation. And of course, being able to make sure that we are given information that can be understood. It's one thing to speak that medical jargon and you've said what needs to be said. However, family members or patients are sitting there, they don't have a clue what you just said. So, being able to speak it to where they can get an understanding and also being able to pause and answer any questions. I think that that is vital, that patients and family members will be able to say, especially the family members, well, she took time out to understand or to see that I understood exactly what she was talking about. I think that is super important, because
Hey,
we
I'm
don't.
sorry to interrupt, but you're cutting out again.
Oh no, guys, I am so sorry. I don't know. Let me try to add this to my phone and see if it's a better connection. Hang on one second. Thank you though, Megan. Give me one moment, guys.
Can you guys hear me?
We can hear you, but now you're echoing.
Okay, is that better? Okay.
Are you speaking right now? Because now I can't hear you at all. I'm so sorry to interrupt.
That's okay. That's okay. I don't know what's going on. Yeah, I'm talking.
I can hear you now.
It's not crazy. Okay. I keep interrupting me when you can't hear me. So I think the last thing I just said was just maintaining presence. Technology messes me up, guys. I can't hardly stand it. Keeping in mind that death is individual, it's very personal, it's not typical in any kind of time, according to their culture and their belief system and their values. And of course, with those unique relationships with their family, friends, and colleagues. So we advocate for those choices in relation to where and with who and how they die. The nurse has to collaborate with those for those patient and family choices. And I think that we need to also kind of tune into that many patients may experience some psychological and emotional things, like they maybe have a fear of the dying process or fear of not knowing, and that nearing death awareness, and may become withdrawn. So these are things that we need to be aware of as well. Medically administered nutrition and hydration, of course, keeping in mind that sometimes patients feel like we're starving the patient to death, or the society in which we live is one where when we give food and when we give hydration, that's caring. But there's little evidence that increasing fluids actually decreases the dry mouth or, provides further discomfort. So as a patient gets closer and closer to death, their perception of thirst and hunger kind of goes away. So there are arguments that are for and against hydration, of course, some that feel that they're going to, the patient becomes dehydrated. And so we have to give them hydration. And then, of course, arguments against that, of course, is going to say that, it could increase their discomfort. So please keep in mind that there's always going to be those arguments for or pro or against. When we talk about some ethical considerations, when we talk about as far as withholding fluids, of course, those cultural influences definitely influence the whole entire death experience. Because for some, food is not just about feeding the body; it's also about those social engagements, dependent upon the culture that they're in, and of course, family gets pretty upset when the patient has no longer to do something, make sure that we just have to keep in mind that we maintain those three basic ethical principles, and that's autonomy, that is that patient's right to self-determination, and that beneficence, where we will do good and to act, and that is doing no harm, respecting the wishes of the patients and the family, but we are not going to bring further suffering or to weigh benefits versus burdens. Resuscitation, in the case that a sudden death, there's no advanced care planning during that time. And of course, sometimes CPR has to be, has been put into place. have some really unrealistic beliefs about survival after resuscitation, based upon, favorable survival that they've seen like in movies where they're resuscitated and they're fine and they go on to live a long life. We know in reality that, outcomes after resuscitation are poor. Survival to hospital discharge is between 0 to 40%. There's also questions about family being present during topic. Some people feel that it has positive results on psychological variables, that it doesn't interfere with medical efforts or increase on the health provider's stress. And of course, there's no result in medio. I think about outside of that. I totally agree with that. But of course, that's something to definitely keep in mind. DCing the devices, of course, also just knowing that, those devices are typically put in place to help with symptoms. And at the end of life, the ICD may cause some unnecessary shocks. So that's something to consider as well. And then the ECMO, maybe like some anoxic brain injury, or there's a poor quality of life. So just keeping in mind that, these are issues surrounding being able to, whether or not to DC those devices. Discontinuing the and relieve some symptoms of heart failure, but over time, may lead some patients to ask that this stuff be taken if they no longer have it. Preloading that patient for breath is sometimes warranted before they stop those drugs. Ventilation here. They may be discontinued after the discussion is had with the patients and the family members. Just keep in mind that strategies for discontinuing medical are also called terminal extubation. Should already have their protocols in place for those clinicians. Talk about DCing. When you think about when it should be discontinued, it's when those burdens outweigh the benefits, or when it's no longer prolonging life, it's only prolonging the death. Talking about organ and tissue donation. Keep in mind that this is in regards to the regulations around that. I don't know if you guys are familiar with places like Genesis, whole body donation. About organ and tissue transplantation, making sure, finding out what actually can be donated. And I think that informed consent, being able to have them informed. Because a lot of times some of the questions they'll ask is, do we have to pay for the cost of the organ donation? Of course not. The donor's family neither pays for nor receives payment for organ and tissue donation. Usually covers their costs. And then, there's a question as to, is this going to disfigure my loved one's body? And the answer to that can, of course, be no, because it doesn't change. In a routine operation. And it also doesn't bother or disrupt their plans that they may have for funeral. Those may be some general questions that they may ask. Talking about requests in medical aid for dying. It's not uncommon for patients to ask. It may come because they got some symptoms that prolong the suffering. They feel out of control. They have anxiety about it. And they have fear of being a burden, whether it be financial or physical, to their loved ones. So this is when they ask those, may ask the nurse to help hasten their death. And of course, this is them wanting death to come faster than it would happen if it took its natural patient. Of course, if they have a progressive, incurable illness, judgment, the nurse just actually needs to assess and be clear on what the patient is asking, explore those motivations as to why they ask that, non-judgment commitment to care, openly discuss the patient's requests with others to eliminate secrecy, and of course, seek that interdisciplinary help as you care for that patient. Patient is aware that we only die once, and or to worry or think that they're going to be by themselves or feel anxious about uncontrolled pain and suffering. Believe it or not, those patients, body parts and dignity, control, and self-esteem. So towards the end of their life, they may choose to be more introspective or focusing on maintaining a sense of self or finding some meaning in life. Spiritual considerations to consider when death is imminent. Of course, be aware of they may have an increased focus on spiritual issues. Be aware of their culture or their religion or spirituality. Please make sure that nurses remember that they play a vital part in getting this care across to the interdisciplinary team. Provide spiritual comfort through your presence, through prayer, allowing them to have their rites and rituals. Also, families may want to bring, favorite hymns or scriptures. Chaplain should be called in on this just to make sure that they're available for, spiritual support. Next, we'll start talking about some frequent symptoms that are kind of associated with imminent death. Of course, the nurse is educated to assess and manage these symptoms, and some interdisciplinary communication is going to be vital during this time. This slide here kind of shows transitioning from living to dying, acute and progressive psychological changes that are related to the disease progression, declining functioning in the performance status, increasing number of and severity, or so need for informal caregiving. And when we get to the point where we determine that prognosis, we know that no one can actually predict the specific time of death. Some patients seem to instinctively know when their death is going to happen. And of course, that prognosis is affected by the disease, the patient's will to live, or the desire or choice to wait for a special event, or for a loved one to get there, or, a birthday or things like that. So just keep and mental processes. The usual road, of course, is sedation, and then lethargy, and then gradual obtunded, leading to a comatose state, and then death. For others, that road may be more difficult, including some confusion and restlessness, delirium, seizures, and then eventually death. Of course, those physical symptoms may vary. Sometimes occur within months, weeks, or days before death. One patient may be confused or disoriented or delirious, while another patient may be totally unconscious. One patient may be weak and fatigued, while another may have a big surge of energy. One patient may be drowsy and sleeping most of the day or night, while another one is restless and agitated. So death, and that's of course making sure that there's no fever present, paying attention to the bowel changes, because they usually have had a lack of interest in food and water. Those bowel changes are gonna take place. If they're on opioids, continue to pay attention and treat for constipation as necessary. Incontinence, of course, you want to assess to make sure the patient's dry to prevent some skin breakdown, which that could cause more desire of food to eat or drink, the inability to swallow, or they may have mouth ulcers, and then pain. So are found in the final days and weeks of life, and that's dyspnea or shortness of breath. That's 56.7% of patients have this. Pain is evident, and also pay attention to the breathing changes where it becomes noisy breathing, and respiratory congestion can be present. Some other symptoms to be aware of course, is delirium. Patients suddenly become just out of it and not really sure. Good assessment and proactive management are critical. Delirium can be a prognostic indicator of death. But as you pay attention and consult with the IDT team, keep the patient's goals of care in mind as you work to develop some management strategies. That myoclonic jerk, whether or not they're on high dose opioids, discontinue any medicines that may be causing these symptoms, and of course be aware of certain conditions such as hypoxia or multi-organ system failure, and of course that immediate treatment for myoclonus is opioid rotation, especially if the patient is on some higher doses of opioids. Talking about opioids, using those in the final days, based on the appropriate assessment and reassessment, of course, can be either sometimes once swallowing becomes no longer a viable route, have to look at things like rectal and also subcutaneous to make sure that they get those medicines. According to the National Comprehensive Cancer Network, they had developed some guidelines for treating patients in pain right before death. And of course, that is to titrate to comfort, analgesia versus reduced loss of consciousness, analgesic dose conversions, and be able to consult out for those situations, and also consider some sedation for uncontrolled symptoms, or palliative sedation as it's known. Make sure that you consider all possible etiologies and treatments. Educate that patient and family regarding those goals and those outcomes, as well as taking a look at it from an interdisciplinary approach. That will be making sure that everyone on the team is aware of basically this is how we're trying to control symptoms, have to be aware of situations. Step up. Being able to look at death being right there. Of course, you're going to notice that decrease of urine outputs, as well as those extremities become cold and mottled. Vital signs change, breathings change, mental status changes, and you may also experience or see some family will often want to be at the bedside during the hours and days before death. And, sometimes they may be uncomfortable when they watch because of fears or other personal reasons that they just don't want to be right there. So I guess it's important to kind of find out in advance what the patient's family is going to want. Is there going to be a bedside family presence for a vigil? Talk about these, talk about some of the common fears that they may have, and provide education and support, for the family that's going to happen during this vigil. They may ask questions like, carving them, how many minutes do we have? So just being able to comfort and assure them, because you won't have those definite answers, but just keep in mind that, sometimes allowing the patient to remember the fact that death is very personal and everyone has as their body different. So we don't necessarily have a textbook explanation, but just being able to be present and explain to the very best of your ability during those times. Once we get past the death and we start talking about bereavement care, of course, that's talking about that communication with the family, because it takes some time and it takes sensitivity in regard to not only to that deceased, but also to those prior to the death, for those next steps, what this is going to look like, and being able to step in and follow up with those technical tasks that there's things that you all have to do, but just make sure that the family understands that we have to remove tubes and supplies and equipment and anything that the patient has, that so making sure that the family understands respect, and it's going to provide dignity for the patient and the family. Place dressings over wounds that may be leaking. That's just respect to the patient, as also to the family. A diaper if needed for incontinence, and you want to align them in proper alignment. Put their dentures in their mouth. Go ahead but allow that family as much time as they need to be able to say goodbye. We think about caring for the body, of course. Family should be allowed to be bedside and, talk and reminisce about their family. This can also help them talk about, air out their grief, if that makes sense. Surely, before the patient died, there's been some conversations to talk about the family rituals or the things that are important to them. So we should make every effort to provide to honor those requests that allow that family to be able to grieve in accordance with however their cultural mores are or what their religion is. So we want to be respectful of that. Getting the room clear, like if they were to die in the hospital, getting as many, outsiders or medical team members out of the way to allow that patient and that family to have that time with their loved one. But to make arrangements so that the family doesn't feel rushed. As much as you can, allow that patient, if they want to be a part of that physical care, their hair or holding their hand. So encourage them as much as they want to do it. Please allow them to do that. The pause, of course, that's that brief acknowledgement between, of the patient's humanity just after the death has been declared. Just tells you about 3 simple parts that one person in the room simply says something like, let's take a pause to honor the death of this patient who was someone's brother, someone's father, someone's. Recognize our own contribution with a statement like, we all work to provide, the very best care possible for this patient, and we should acknowledge that care. And of course, everyone just stands silently for 30 seconds or so just to reflect as a moment of silence before going on. Of course, that bereavement follow-up support happens through phone calls, through cards, through attending the funeral. Have closure with the deceased. I don't know if any of you on the call, just last week we had a bereavement facilitator conference in Gulfport, and I encourage you, if you have never been, to please come, because it's an opportunity for bereavement specialists, for chaplains, for social workers, different members of the ID team to come together and kind of stay up on as far as things that relate to guidelines in bereavement care, but then also to kind of talk about what works in their program, what's not working, just to be able to share and to network. So just always take a look. It's usually in October. It's a fall bereavement session. So please, if you haven't ever seen that, please look for that and consider joining us. Of course, thinking about for further information, of course, on bereavement care. Remember the loss, grief, and bereavement that we did in the last module has a services that we can offer families, and also sending cards on those anniversary dates, or you're making phone calls, because the bereavement happens for 13 months after the death of that patient. And the bereaved tend to, I can tell you this, every bereaved person has different needs. So we have a responsibility to be able to reach those needs through conversations, and maybe through the cards with a follow-up call, just to see what those patients may need. Please remember the child of the deceased, because remember that they all have different developmental stages. Be open and honest. The more of a child, young or old, that's been involved in the care during the terminal phase of their parent's life and the activities, the better able the child should be able to cope with the bereavement. They questions, and of course they should be responded to in terms that they understand. In conclusion, we just know that family members are always remember the last days, those hours, the minutes of their loved one's life. Nurses, they have a unique last moments, just to be able to not only provide excellent care and to assess, but to manage those physical symptoms, get to those psychological, those emotional, plugging in IDT team members as necessary, being able to also death, finding out for them what a good death looks like according to their culture and their rituals, and then being able to provide that as much as possible. Being able to communicate with the other team members as needed. When we care for the patient and family at the time of death, provided beyond those that we saw earlier in terminal illness care. Being able to closely collaborate and tag in with that, the other members of the team, and recognition of individual patient and family needs. That is super important. We have to be able to make sure that we are able to do that as well. I'll stop sharing my screen right here. And I'd like to ask if there's anyone that has any questions. And I'll tell you, I know that I have Shay and Randy and Mackenzie on. Who's the Zoom user today? Is that Megan? Does anyone have any questions? Earlier, send me an email at marquetta@lmhpco.org to let me know the sessions that you have missed, or if you have been in attendance at all. I'll check that against my video recordings just to make sure. Of course, it's an honor system. So I ask you, please don't expect certificates, because that's kind of a tedious process, just to kind of make sure, because I have to go through the entire list of all of the registrants. even those that are not on here today. So I will be as expedient as I possibly can when it comes to making sure that you guys get certificates for this. But I also want to make sure that I am properly applying those CE credits to those people that were actually present. Again, thank you for your patience in that we were just trying to do something that typically is an in-person kind of experience, but we thought that we could make this a, lunch and learn to kind of facilitate. So also, if you don't mind, shoot me an email on your thoughts on being able to provide this session during a lunch and learn. I'm open to take a new experience. I'd really like to hear from you guys, what you guys thought about that. Does anyone have any questions as it relates to the final hours today?
I think I know I missed a session. I'm just not sure which one it was, and I don't know how to figure that out.
Okay, Randy. If you want to get with me after, I'll go back because like I said, I have to go back. Who put in a chat box if they were there. But at any rate, I'd be happy to, I'll find that out if you find it before me, and I'll be happy to shoot you over because you were here for the very first one, weren't you, Randy?
Yes, ma'am. I've been here for all of them. I know that I missed one.
I think, was it the week of the hurricane, the weather?
I think
I got you. Because the reason I said that was because I had several people miss that session.
okay.
But if you don't mind, you and I we'll figure it out via email, because I can just send it to you because I have it recorded. And then, of course, once you take a look at it, you let me know, and I'll make sure to get you that certificate.
Sounds good. Thank you so much.
Thank you. Thank you. Well, listen, no fear. We just happened to get through a little bit early. You got, like I said, trying something new. Something that could be helpful for you guys in what you do. Please, if you are an administrator and you're thinking of onboarding, we'd love to be able to utilize this as a part of the onboarding. Going to be providing a spring session of this in March. I think it's scheduled to start March 6th, and we'll kind of do like we've done this time, and that's a lunchtime every Thursday in the months of March and April. So if you have someone coming up, if you have new staff coming on board, please consider registering. I think for the money, it's a good value as far as CE credits for the money that's being spent. But just know that, LMHPCO, in an effort to make sure that you guys get every single thing that you need, all that you would like to see or you'd be interested in seeing, please don't hesitate to reach out. Also know that we are in the works of another spiritual intensive. In the conference in July, it was discussed amongst some social workers that we're looking to put together a social work support group, just to kind of see if, to get a 30 minutes a month or whenever, just to come together to see what works and what doesn't work. It's across agencies, just another networking opportunity. And also, if you guys, what we're here for, to do the very best we can to be able to provide education to you guys. So if you guys don't have anything further, I'm going to take off. Expect to see some emails from you guys that are on today, just to kind of remind me where you are. Like I said, give me a few days to kind of get this sorted out and make sure that everyone gets the proper credit that they need. And then certificates will be coming forthwith. Thank you, guys. And thank you so much for all that you do. Thank you for taking this time out of your busy schedules for this month and last month to take some LNEC information. Thank you so much. Have a great day.